Ever wonder, like, what are all those tubes and wires actually doing when you see someone in the ICU?
It can be kind of a mystery, right?
Totally. So today we're diving deep, no pun intended, into the world of medical device complications in the ICU.
And it's a world with more to it than meets the eye. It's easy to think of these devices as just tools, but they all have their quirks. Each comes with its own risks. And honestly, there are some surprising facts in this research.
Quirks, risks, and surprising facts.
Huh.
All right, you've got my attention. But before we get into all that, let's set the stage a bit. This deep dive is thanks to you listeners. You requested a closer look at, well, this whole research review on complications from all these different devices they use in the ICU.
And this is something that, even if we're not all doctors and nurses, it's likely most of us will experience the ICU at some point, either ourselves or knowing someone who has.
It's about being an informed patient or an informed friend or family member, right?
Exactly. And being able to advocate for your loved ones or even just understand the decisions that are being made. And this review, it really gets into those risks that we don't always talk about. We hear a lot about infection, which is obviously a huge concern, but there are also mechanical complications that are just as important.
Okay, so let's unpack this a bit. We're talking ventilators, different kinds of catheters, ECMO. Where do we even begin?
Well, the article itself gives us a pretty logical flow, starting with what are called vascular devices. Those are the ones that are really essential for delivering meds, keeping track of vital signs, all that.
So kind of the VIPs of the ICU, you could say.
Pretty much. And when it comes to vascular devices, the real heavy hitters are central venous catheters, or CVCs. You've probably heard of them.
CVCs, yep. They're used in, what, about two-thirds of ICU patients, right?
That's right. They're those little tubes they insert into a major vein, often in the neck or chest. They're crucial for all sorts of things in critical care. But here's the thing. Because they're used so often, the potential for something to go wrong is also higher.
Well, that makes sense. I mean, sticking a tube into a major vein doesn't exactly sound risk-free. And I do remember the article mentioned a kind of scary stat. Almost half of all ICU patients experience some sort of complication related to a device. That's huge.
It is a huge number, and it underscores why it's so important to really understand both the good these devices do and the potential downsides. With CVCs, for example, the research found this really interesting pattern. There's actually a lot of geographic variability in how much they're used.
You mean like some regions use them way more than others?
Exactly, and it makes you wonder, why is that? What's driving those regional differences in medical practice? That's a whole other deep dive waiting to happen.
It really is. But focusing back on the complications themselves, what kinds of things can actually go wrong with these CVCs?
Well, it can be as simple as some discomfort or a little bruising at the insertion site, but we're also talking about the potential for more serious things. Imagine, for instance, accidentally nicking a vein near the heart during placement.
Oh, wow. Yeah. That's not something you want to hear from your doctor. Oops, I nicked something.
Right. And that's why the way they insert these things, the guide wire technique, it's super important to minimize that risk of vascular injury.
It makes sense that experience would play a role on something so delicate.
Absolutely. And the research actually backs that up. Clinicians who had done fewer than 100 of these catheterizations, they had a much higher risk of complications. So it's not just about the technology, it's about the skill of the person using it.
A good reminder that even common procedures have inherent risks.
Yeah.
So aside from, poking the wrong thing, what else can happen with these CVCs?
Well, there's always the risk of bleeding. It's usually not serious, but it's something to consider, especially in patients who already have issues with blood clotting.
So those underlying health conditions can really make things more complicated.
For sure. And then there's the risk of something called a pneumothorax, which is basically a collapsed lung. It happens more often with certain insertion sites, like if they go through the subclavian vein.
That sounds unpleasant, to say the least.
It's not great, but the good news is that using ultrasound guidance during the procedure can really reduce that risk.
Okay, that's reassuring. At least technology can help mitigate some of these risks. What about things like air embolisms? Aren't those a concern with any kind of line they put in?
They can be, yeah. It's scary to think about a bubble of air getting into the bloodstream, but thankfully with CVC placement, air embolisms are very, very uncommon.
That's good to hear. There are enough other things to worry about with these things.
That's for sure.
So what about thrombosis and infection? Those always seem to be concerns with any kind of implanted device.
They are, and those are definitely things the article talks about, but we'll actually be digging deeper into those aspects when we talk about some of the other devices.
Okay, so stay tuned for more on that.
Exactly. But for now, the main takeaway with CVCs is this. If it's possible to avoid putting one in altogether, that's always the best case scenario.
Makes sense. But easier said than done sometimes, right?
Hmm.
Especially if you're in the ICU.
You're right. It's not always a choice. But the research does point to some promising alternatives, like using something called short-term peripheral vasopressors. There's more and more evidence suggesting it can be a good option in some situations.
So it's like a potential shift in how these situations are managed.
Exactly, which is a good thing.
Good.
It means medical practice is always evolving to try to do what's best for patients.
Speaking of doing what's best for patients, what about those arterial lines? They're another type of vascular device, right? And they're used pretty often in the ICU too. Yeah.
You're right, they are. Millions of them are used every year. And just like CBCs, they come with their own list of potential complications.
All right, so spill the tea. What do we need to know about arterial lines?
Well, they're usually placed in the radial artery in the wrist, although sometimes they go through the femoral artery in the groin. And one thing the research pointed out is that a lot of what we know about complications with these lines actually comes from when they're used during surgery. Not as much is known about what can happen when they're left in for a longer time, like they often are in the ICU.
So kind of a data gap when it comes to long-term use.
Exactly. And that's something the research really highlighted as an area where we need more information. But with that said, let's dive into what we do know about arterial line complications. The article mentioned they share some similarities with CVCs, but there are some important differences too.
All right, lay it on me. What sets arterial line complications apart?
Well, take vascular injury, for example. With arterial lines, there's a higher chance of something called a pseudoaneurysm forming. It's basically a blood-filled sac that forms in the wall of the artery.
Pseudoaneurysm. That doesn't sound good.
It's not ideal, no, and it seems to be more common when the line is placed in the femoral artery rather than the radial artery.
That makes sense. The femoral artery is bigger, right?
It is, and because of that, there's also a bigger risk of serious blood loss if a femoral line isn't placed exactly right.
Okay, so placement is key here.
Absolutely. They actually have specific guidelines about where it needs to go, like making sure it's distal to something called the inguinal ligament.
See, this is why I love these deep dives. I'm learning so much anatomy. But seriously, it's amazing how these seemingly small details can make such a good difference.
They really can. And it highlights how complex the human body is and how much care needs to be taken with these procedures.
So what else can go wrong with arterial lines? We've got the potential for bleeding, pseudoaneurysms.
Hmm.
What else?
Well, there's also the risk of nerve damage, especially with the ones placed in the wrist, because there's a nerve, the median nerve, that runs pretty close to the radial artery.
And we're not just talking about a little tingling here, right? The article mentioned it could even lead to long-term problems with hand and wrist function, which would be awful.
Yeah, it could. It's a serious complication for sure. And then on top of that, there's also something called vascular occlusion, which basically means the artery gets blocked.
Is that common?
It actually is pretty common with arterial lines, but the good news is that it's usually temporary.
Usually, but not always, I'm guessing.
You're right. In a small percentage of cases, that blockage can become permanent, which can obviously have some serious consequences. And there's a test they can do beforehand, the Allen's test, to check the blood flow. But even that isn't foolproof.
So even with all our fancy medical technology and tests, there's still a margin of error.
There is. And of course, just like with CVCs, infection is always a risk, although it's less common with arterial lines.
It seems like with both of these, CVCs and arterial lines, the big takeaway is really, if you don't absolutely need it, don't use it.
That's the gist of it, yeah. And the article even questions whether they're always necessary, even for conditions like sepsis, which has always been kind of the textbook reason to use them.
Really?
Yeah.
That's interesting.
Yeah, there's a growing body of evidence that suggests their benefit might not be as clear-cut as we once thought.
Wow, that's a pretty powerful statement. It really makes you stop and think about the potential downsides of overusing these devices.
It really does. And it all comes down to carefully weighing the risks and benefits for each individual patient. There's no one-size-fits-all answer.
That's a good point.
Mm.
Speaking of things that are essential but come with risks, what about those devices that help us breathe? Airway devices. Okay, now we're getting into some serious stuff. I mean, we all kind of know what a breathing tube is, but the intricacies of like when and how they're used, that's always kind of fascinated me.
It is fascinating, and the article goes into quite a bit of detail about two main types of airway devices. Endotracheal tubes, which are the ones they insert through the mouth to help with breathing, and then tracheostomies, which is where they actually create a surgical opening in the neck to access the trachea.
Right, right. And obviously both of those can be totally life-saving. But like we've been seeing with all these devices, there's also the potential for things to go wrong.
Exactly. And the research really doesn't shy away from that. It goes into quite a bit of detail about the potential complications with both.
So hit me with it. What about endotracheal tubes? Those seem like they would be delicate, to say the least.
Well, prepare yourself because the article says that almost half of all patients who have an endotracheal tube placed experience some kind of complication.
Whoa, really? Half. I knew there were risks, but that seems really high.
It's a significant number, and it really highlights that balance between how necessary these devices are in critical care, but also the very real potential for things to go wrong. And the research kind of breaks down those complications into two main categories. Things that can happen during the actual insertion process, and then things that can happen after the tube is already in place.
Okay, so let's start with insertion. I mean, I'm not a doctor, but I can imagine having a tube put down your throat is not exactly a walk in the park.
You are correct about that, and it's not just about discomfort. There's a risk of some pretty serious things happening during that process. We're talking cardiovascular instability, dangerously low oxygen levels, even cardiac arrest. And the article really stresses how surprisingly common these complications are.
Hold on. How common are we talking here? Give me some numbers.
Okay, so for cardiovascular instability, it happens in about 43% of intubations. Severe low oxygen saturation occurs in around 9% of cases. And even cardiac arrest, while it's thankfully less common, still happens in about 3% of intubations.
Wow. Okay, those are not just minor blips on the radar. That's serious stuff. It really makes you realize how crucial it is to get that intubation right the first time.
Absolutely. And the article actually talks about some of the strategies that have been shown to improve first pass success, which basically means getting it right on the first try. For example, experience matters. Senior clinicians, the ones who have done a lot of intubations, they have significantly higher success rates.
That makes sense, right? Practice makes perfect, as they say.
Exactly. And then there's the technology they use. Using something called video laryngoscopy, where they use a camera to guide the tube, that seems to be better than the traditional methods, and making sure the patient is properly pre-oxygenated before they start.
Oh, right. So giving them as much oxygen as possible before they put the tube in.
Exactly. And this one's kind of interesting and maybe a little bit counterintuitive. Using a bag mask ventilation after they give the induction drugs also seems to help, even though you might think that would increase the risk of aspiration.
Huh. That is counterintuitive.
Okay.
It just goes to show you can't always go with your gut, right?
Mhm.
Sometimes the research throws you a curveball.
It really does, and it highlights how important it is to keep doing research, to keep questioning what we think we know. Another thing the research looked at was the choice of drugs they use for the actual intubation. It seems like propofol, which is a really common one, might actually be riskier than we thought, while ketamine might be a safer choice.
Interesting. So even the meds they use are constantly being evaluated and refined.
They are. It's always evolving. But let's move on from insertion to some of those post-insertion complications because the article gets into some pretty intense possibilities there.
Okay, yeah, lay it on me. What else can go wrong once the tube is in place?
Well, one of the most common issues is laryngeal injury, and it's surprisingly prevalent. One study they cited found it in a whopping 83% of patients who had been intubated.
83%. That's like almost everyone.
It's a huge number. Now, the good news is that most of the time those injuries are pretty mild. But you can have more serious laryngeal injuries, and those can lead to long-term problems with voice and even breathing.
Wow, so even if it seems minor at the time, the impact can be significant down the road. What other complications do they talk about?
Another one is vocal cord paralysis, which is often caused by pressure from the tube's cuff on the nerves that control the vocal cords.
This is not even always about direct damage from the tube itself. It's also the pressure it can put on surrounding structures.
Right. And then there's tracheal stenosis, which is a narrowing of the windpipe. That's often linked to having the tube in for a long time, so that's something they have to be really careful about with patients who need long-term ventilation. And then there's tracheomalacia, which is a weakening of the trachea itself, again, often related to pressure from that cuff.
Man, that cuff seems like kind of a necessary evil. It's needed to keep the airway secure, but it also seems to be a major culprit in a lot of these complications.
Exactly. And the article actually calls that out. They call it the cuff pressure conundrum. Basically, we know it's a problem, but there's no magic number for how much pressure is safe.
So it's a constant balancing act, trying to find that sweet spot between keeping the airway open and not causing damage.
Exactly. And as if all of that wasn't enough, there's also the risk of fistulas forming, which are abnormal connections between the trachea and other organs.
Oh, no. Okay, those sound bad. How common are those?
They're actually pretty rare, thankfully, but when they do happen, they can be life-threatening. One example the article gave was a tracheoesophageal fistula, which is where the trachea erodes into the esophagus.
Oh, wow. Yeah, that does not sound good at all.
It's not. And there's this thing called a sentinel bleed, which is basically a small amount bleeding that can sometimes be an early warning sign of a tracheoarterial fistula, which is where it erodes into a nearby artery.
So that's definitely something you want to catch early.
Absolutely. And that actually brings us to tracheostomies, which are often seen as kind of a step down from long-term intubation. They still have their own risks, of course, but the good news is the research shows that whether they do the tracheostomy surgically or percutaneously, which basically means through the skin, the complication rates are pretty similar.
Okay, so both methods have a similar safety profile.
Right.
But what about the complications themselves? What kinds of things can go wrong with a tracheostomy?
Well, a lot of them are actually similar to what we see with endotracheal tubes. Tracheomalacia, fistulas, stenosis, those are all risks. But one interesting difference is with tracheal stenosis, where that narrowing happens. In tracheostomy patients, it can happen above the stoma, at the stoma, or below the stoma, which is that opening in the neck.
Huh. So the location of the problem can actually be different depending on the procedure. That's interesting. What else? What other complications are specific to tracheostomies?
Well, one that's often overlooked is loss of voice, which makes sense when you think about where the tracheostomy is located.
Mm-hmm.
But the impact that can have on patients is huge. It affects their ability to communicate, their quality of life.
It's easy to forget about those quality of life issues when you're focused on just keeping someone alive, but they're so important.
They are. And thankfully, there are things that can be done to help. Early intervention with speech therapy is really important. And there are also devices like Passimir valves that can help patients regain their voice. But it's definitely something to be aware of.
It really highlights how these interventions, as necessary as they can also have a really big impact on someone's life, even once they're out of the woods, so to speak.
Absolutely. And that actually leads us to the last category of devices the article talks about, which is ECMO, or extracorporeal membrane oxygenation.
ECMO. Okay, that's the big leagues. I feel like that's always the last resort for the sickest of the sick.
It pretty much is. It's a system that basically takes over the job of the lungs, and it's used when nothing else has worked.
ECMO.
Yeah.
Yeah, that's definitely not something you want to hear your doctor say, well, time to bring out the ECMO. It means things are pretty dire.
It really does. It's a last resort for a reason. And because it's used in those really extreme situations, when patients are already incredibly sick, there's always going to be a high risk of complications.
That makes sense. It's like the sicker you are going in, the more likely something is to go wrong.
Yeah.
But even with that in mind, what does the research tell us about ECMO complications? What kinds of things can happen?
Well, there's a registry, the ELO-SO registry, that tracks outcomes for patients on ECMO, and it shows pretty high rates of complications across the board.
Yeah.
Bleeding, for example, is always a concern with any kind of invasive procedure. But with ECMO, it's not just about external bleeding. Blood clots forming inside the ECMO circuit itself, that's a major issue.
Why is that? Is it because of the artificial surfaces inside the machine?
Exactly. When blood is constantly in contact with those artificial surfaces, it disrupts the normal clotting processes.
Wow, so it's like your body is trying to do its job, trying to heal, but then the machine is almost working against it.
It's a constant battle. And then on top of that, you have to worry about neurological complications. Stroke is a risk, of course, but there's also this thing called north-south syndrome.
North-south syndrome. Okay, now you've got to explain that one. That doesn't sound good.
So basically, because of the way the blood flows through the ECMO circuit, there's a chance that the brain might actually be getting blood that has less oxygen in it than the rest of the body.
Wait, what? So even though the machine is supposed to be oxygenating the blood, it's possible for the brain to still be deprived of oxygen?
It's pretty counterintuitive, right?
Yeah.
But yeah, it's a potential complication. And then there are the usual suspects, like infection. Always a concern with any kind of medical device, but ECMO can actually make it trickier to detect infections.
How so?
Well, think about it. One of the main ways we know someone has an infection is if they have a fever, right? But ECMO itself can actually mask fever.
Oh, wow, that's right. So it's like trying to solve a mystery, but you're missing half the clues.
Exactly. And then let's see, what else? Oh, vascular complications. Those are pretty common with ECMO too, especially something called limb ischemia, which basically means there's not enough blood flow getting to the limbs.
Is that more of a problem with a specific type of ECMO?
It seems to be more common with the type that's used for respiratory failure, yeah. But they do have these special cannulas they can use to try to minimize that risk. And then, of course, there's always the chance that something mechanical could go wrong with the ECMO circuit itself.
Oh, right. And those machines are pretty complex, I imagine.
They are. And if something goes wrong, it can be life-threatening, so they always have to have backup circuits ready to go just in case.
It sounds like being on ECMO is kind of like being in this really precarious balance. Like,
Yeah.
it might be the only thing keeping you alive, but at the same time, there are all these other risks you have to manage.
That's a good way to put it. It's a high-stakes situation, for sure.
Yeah.
And even if you survive, that's not the end of the story. There's growing recognition of something called post-ECMO syndrome, which is basically a whole constellation of long-term issues that survivors can face. Everything from physical problems to cognitive issues to psychological trauma.
Wow. So the impact of ECMO can be really far-reaching. It makes you realize it's not just about surviving the immediate crisis. It's also about what comes after.
Exactly. And that actually brings us to something I think is really important and something the article really highlights: the patient experience. We've been talking a lot about the technical aspects of these devices, the risks, the complications, but at the end of the day, these are real people going through these things.
Absolutely. And the article actually includes a section with direct quotes from patients about their experiences.
Hmm.
And it's powerful stuff. One patient talked about having their right ventricle punctured during ECMO cannulation, needing 3 sternotomies, and still dealing with chronic pain 7 years later.
It's a good reminder that even when these procedures are successful, they can have a lasting impact. Another patient mentioned being unable to sleep with anything touching their neck, even years after having central lines placed in their jugular veins.
Wow, it's like the trauma, both physical and emotional, stays with you.
It really does. And it highlights the need for more awareness of these long-term effects, not just for patients, but for their families and caregivers, too.
Absolutely. And it's not just the physical scars either. The psychological impact can be just as profound. One patient talked about feeling completely dehumanized when the decision was made to put them on a ventilator.
It's that loss of control, that feeling of being trapped inside your own body that can be so difficult to cope with. And it really underscores the importance of communication, making sure patients and their families feel heard and understood throughout the whole process.
For sure. One patient even mentioned the stress of just having medical staff rushing around them, talking about them, but not really to them. It's like you become this case, this illness, rather than a person.
That's a really good point. And then there's the issue of restraints, which obviously are sometimes necessary in the ICU, but they can have a lasting impact too. One patient in the study talked about how they were so agitated and delirious that they ended up severely damaging the tendons in both arms from struggling against the restraints, and it ended up costing them their career.
It's heartbreaking. And it
Yeah.
really makes you think about that balance, that constant tension between doing what's necessary to keep someone alive, but also minimizing harm and respecting their dignity as a human being. How do you even begin to navigate that?
It's not easy. It takes a lot of compassion, a lot of communication, and a willingness to really see the person, not just the illness.
Well said. And I think that's a good note to end on. This has been an incredibly thought-provoking deep dive, to say the least. We've learned a lot about the complexities of medical devices, the risks and benefits, the things that can go wrong, and the importance of the patient experience.
It's been a pleasure diving deep with you.
Always a pleasure. And to our listeners, thank you for joining us on this journey. Remember, knowledge is power, so keep those questions coming. Until next time, stay curious.